Good morning. How are you all doing? Can you hear me okay? It's great. So I'm, to begin, these are my financial disclosures. For those of you in the startup world, when I first sent in my paperwork, we still had a startup, but this recently got acquired, so we're very excited about that. But all of the funding that I have and the research I'm going to show is none of the funding agencies have told me what to say. I'm very thrilled to be here. Of course, this is a great opportunity to meet Dr. Han. Dr. Han is actually on the expert advisory board for the Center of Surgery and Public Health where we work and was just out in Boston with us, so thank you so much for that, Dr. Han. I get the opportunity to spend time with my good friend Arden Morris, another center director. I get to meet one of my, what I would call sponsors in the surgical world, Dr. Spain. By the way, does everybody know that Dr. Spain was just elected president of the AAST? It's a really big deal, Dr. Spain. It's a really big deal. And then, of course, my good friend Kristen Stoudemire, who I serve on on several committees in the trauma world. Another reason why I'm very thrilled to be here is this. This is my extended family, my parents, my older brother, my younger brother, my sister, and our 9 cousins between all of us. And I wanted to show this picture because all of them live right here in Saratoga, and you have provided care here at Stanford for probably each one of them. And I want to thank you for that, and I know some of the colleagues in the trauma department had to take care of my mother once, and I'm really, really appreciative of that. Another thing is that this is from an annual family get-together. This was at the new part of Yosemite that just opened up. And this annual family get-together has something to do with Stanford, and I'll tell you what it is. When I first got recruited, Mary, to the faculty at Johns Hopkins, back then we had no children, none of us did, and my parents and brother were visiting me in Baltimore from over here. And there was a summer picnic that Dr. Freischlag has, our chair of surgery. And so I was like, oh, we should all go to this summer picnic, the Hopkins Surgery Summer Picnic. So we go there, and Dr. Freischlag, as she is, very sweet, she stood at the entranceway and she's shaking everybody's hand. And so I show up there with my mom, and Dr. Freischlag says, oh, this is your mother? And she, like a good leader, she says, we're so thrilled that we've been able to recruit him to the faculty. We're so excited that he's going to be here. And then, of course, my mother says to that, well, you're excited, but I'm not. And I look at my mom, I'm like, what are you doing? And she's like, this son of mine, I raised him, I sent him to medical school. He should have been closer to me, take care of me. I have all these illnesses. He just talks about Hopkins, Hopkins, Hopkins. If he was any good, Stanford would have taken him. And so I said, well, so then Dr. Freischlag, she's a smart person. She says, these sons, they need to take better care of their moms. So you tell me when you want him to come every year, and I will make sure he comes. Do you want him to come on Christmas? And my mom says, no, Christmas he should be working for everybody else. He needs to come on Eid, because that's what I celebrate. So she's like, okay, I will make sure he comes every year on Eid. And for the past 12 years, this has become our family tradition that I come out to California and spend time with him. So to all you people at Stanford, thank you for setting our family tradition there. Now, the learning objective today is to talk about the association between unconscious bias and clinical assessments. And then I'm going to try to present this concept of cultural dexterity. Now, I'm sure all of you would agree with this slide. Equality is the cornerstone of medicine. And one of your visiting students promised me that she would tweet this, Miss Occur from Boston, so thank you so much for doing that. Really appreciate it. But most of us here, who would disagree with that? Anybody? You probably wouldn't raise your hand, but anyway. But it turns out that there are several surgical disparities that are still present, right? I mean, the disparities I have listed here are, you're not probably surprised hearing about these disparities or looking at them, right? But you can look at them and think, well, a lot of this has to do with access to care, right? And how people got diagnosed late or the quality of care they're receiving and so on. But what about trauma care, right? Trauma care should be the great equalizer. That trauma is completely colorblind and that we don't care what kind of insurance you have. Whenever you come into the emergency department, we're just going to take care of you no matter who you are. But turns out that there were some initial data suggesting that there are racial disparities after traumatic brain injury amongst children, and we decided for our first study to explore that back in now 2006. And we wanted to look at functional outcomes for children who had traumatic brain injury, and this is what we did. We took about 41,000 patients in the National Pediatric Trauma Registry, the NPTR back then, and we compared about 4,700 white kids to 1,200 black kids to about 1,000 Hispanic kids, okay? And this is what we found. The red line is the reference group, that's white children, and we compared black children and Hispanic children. We found no difference in survival. So mortality, adjusted odds of mortality, again this is adjusted for injury severity and so on, was the same, but black children were more likely to have to go to rehab, more likely to have a disability in their ability to talk, and their ability to walk, and in their ability to feed themselves. So we found some disparity where it wasn't enough to kill the kids. Now remember, very few children do die though. But we found this disparity in kind of what happens to them after they get fixed up from their initial injury. Now whenever you have a finding like this as a clinician, you want to try to bring this home, right? You want to try to understand how this might work for any one of your patients. And so this is a patient I want to just discuss with you. This happened on August 11, 2006, and I remember the date very well because it was my first night on call as a trauma attending, right? David, do you remember your first night on call? Yeah, it's usually a remarkable night. Now this was another remarkable night. This young woman comes in, she's shot, she's hypotensive, unstable, goes right up to the operating room, right? And the OR, pulseless, cross-clamped her aorta, had a major IVC injury, small bowel injuries, and so on, and she survived. This is back when we had just started damage control operations. We were giving a lot of fluid to people, so it took a much longer time to close them. And so she had like 3 takebacks back and forth to the OR, ICU, OR, ICU, OR, ICU. Eventually got closed at about day 7 or so, extubated, on the floor day 12, and now on day 17 is refusing all care. So who is a first, second, third year attending? Anybody here? All right, so you've trained all your life to be able to do this, okay? And you have this patient who's your first big save as an attending, and she refuses all care. She doesn't want you to come in the room. If anybody wants to go take her temperature, draw some blood, she throws them out. How would that make you feel? Frustrated? How would that make you feel? Well, I got to tell you, you're still being kind with the frustrated because we felt that she might be ungrateful. We did all this for her. And she is not appreciative of all the work. But this was not just any person who was shot. This was a young girl who was taken hostage. The other person who involved with this had taken her hostage, ran into a convenience store, shootout between Baltimore police and this bad guy. She got shot. By the way, he got shot as well. He was rushed in right behind her. It was a scene out of the movies. Brand new trauma attending. She's being rushed to the operating room. The other person comes in. He's unstable. I go up to the OR with him as well. Debu Bosi begins the case on her. I cross-clamp. He's now pulseless. Open up his chest, cross-clamp his aorta. Elliot Hout comes in as the back-end attending. He's like, Haider, what are you doing? I'm like, what do you think I'm doing? Anyway, he survived as well. By the way, Elliot lost more blood than me. I think he needed 50 units or something like that compared to my 30-something. So we knew that this poor girl was suffering from this. And what she was really suffering from was an early form of PTSD where whenever we touched her or talked to her, she felt like those moments when she immediately came into the trauma bay where she was hypotensive and in shock and scared and felt like she was going to die, right? She would feel like that every time one of us would go talk to her, but we didn't give her the benefit of the doubt. I didn't give her the benefit of the doubt. That's probably why she was acting the way she was, and she was not ungrateful, and there was no reason for me to have been frustrated. Now, when we look at these kind of disparities, you wonder, why they occur. And when we started doing our work, we thought that, well, maybe this is not just about race. Maybe there's some social economic disparity going on and so on. And back then, the best proxy we had was looking at insurance status. So for our next study, we looked at insurance status and tried to understand the association between race, insurance status, and outcomes. And this time, we looked at the National Trauma Databank, and we did this for adult patients. We had about nearly 400,000 patients, and we did what at that time was thought to be the state-of-the-art risk adjustment methods. And this is what we found. Compared to a white insured patient, so this is the white patient who's insured, a black patient who's similarly injured and has insurance is 20% more likely to die. And if it's a Hispanic patient, 50% more likely to die. So this is similar injury and insurance. Now compare that white patient to a similarly injured, uninsured white patient, and you're 50% more likely to die. And then you add them both up, and you find an exponential increase in the odds of mortality after similar injury. So we found that there was probably an interaction effect between race and insurance and so on. Now, when those papers came out, it made a big splash. This is nearly 10 years ago, and I got to give talks at various places. But more importantly, what it led to the creation of what's called the national, or what was then called the National Disparities Working Group. At that time, Susan Brundage was here from Stanford, and she was also part of that group. And many other folks from across the country got together to create this working group. And together we tried to apply a public health problem-solving approach to the problem of healthcare disparities in trauma. And the first step was identifying the problem and creating awareness. And so this group got together, and for one of the things they did is to publish this meta-analysis. And you'll see these are all different authors. That's one of our papers. And then when you put them all together on the meta-analysis, you'll notice that about 20% more likely to die, black patients versus white patients after severe injury. And so the meta-analysis almost reaffirmed the results that we had a few years earlier. That was, to create great awareness. But even with this kind of work, when we did a survey of surgeons, and these are fellows of the American College of Surgeons, to ask them if they thought about what they thought about disparities, most of them said that they believe the data on healthcare disparities is actually very weak. They further said, well, if there are healthcare disparities, they're certainly not in my hospital, certainly not in my practice. But most importantly, they blamed the patient. That we, as surgeons, said that 90% of this is because of patient factors. So it's not us. We didn't do anything wrong. It's all the patient. That's why these disparities occur. Now, the second step was to try to understand the mechanisms that lead to these disparities. And so what we did is that we serially investigated everything we could think of that could lead to healthcare disparities in trauma. So we looked at host factors, pre-hospital factors, we looked at provider factors, we looked at post-op care and rehab, and so on, and tried to see if this impacts outcomes. And so for the next 15, 20 minutes or so, I'm just going to focus on one of those mechanisms. Amongst the providers, does unconscious preference make a difference? Do we care if a person is black or white? Does that make a difference? Or the only thing when a trauma patient comes in is the only thing we care about, can people see this open book pelvic fracture, right? And I'll talk about this other case in just a little bit. Now, I don't think that people go to med school to treat people differently. But it might be that we unconsciously, because of the way we grow up or where our experiences have been, we unconsciously have opinions of people, and those opinions of people or types of people color the way we interact with them and potentially color the way we treat them. Now, there's been a lot of work on unconscious bias secondary to this thing called the race implicit association test. Has anybody heard of this thing? If you have, raise your hand. So about half of you have heard of this thing. It's a test. It's a computerized test of unconscious preference. And what you do is that there's these words, and you take these words and you see if you take a good word, and if you're faster at pairing the good word with a person who looks like this versus a person that looks like this, you have a preference to a person who looks like that. That's kind of how it works. And this is how these pictures look and that's how the pairing is supposed to occur. Now, more than 1 million people have taken this test. 1 million Americans have taken this test. And I'll need some help from somebody in the audience. Are there any other medical students back there? You are? Okay, great. Okay, so you're going to help me out here, right? This is going to be tough. Here we go. Can you add 27 plus 27? 54, I could hear it well. Okay. Can you add 16 to that? 70, great. Good job. Very good. Round of applause for you. That's great. So 70% of the people who've taken this test, right? 70% or so of Americans who've taken this test have an unconscious preference towards white. I want you to remember that 70%. The question is, do these unconscious biases impact how we treat patients? And there are multiple medical studies that suggest that they do. Perhaps one of the best studies is from Dr. Lisa Cooper. Lisa Cooper won a MacArthur Genius Award, and I was very privileged to have been one of her mentees during my K Award training. And what Dr. Cooper did is that she audio taped interactions between family practice practitioners and their patients, and did that for hundreds of hours. Now, mind you, these family practice practitioners know that they're being recorded, right? But even with that, when they look at the transcripts or listen to the audio recording, they found that those who had unconscious preferences against whites, blacks, implicit bias against blacks, there was more verbal dominance in that, they would not elicit questions from them. They would tell them what to do versus trying to work with them to figure out what was the best solution for their issue. And the patients felt that. The patients felt that their care was less patient-centered. And most importantly, the patients said that we wouldn't refer our friends and family members to those doctors. The patients didn't know which doctors had unconscious preferences, by the way. That's just how it shaked out. Now, when we thought about this and how it might impact trauma surgery, we were concerned that it would be even more operative in the trauma world because, when does trauma happen, right? It happens at night, when we're tired, when we're cranky, when you have less cognitive luxury to give people the benefit of the doubt. And so we did a group of studies to determine the association between implicit bias and clinical assessments. And what we did is that we would give clinical vignettes, and we would either have a white patient in there or a black patient, or we would change their social class using this kind of NAM Powers social class determinations. And then we would ask these people that we were testing how they would treat a certain patient in a certain clinical scenario. And so for the first study, we looked at medical students because we were like, we found this amongst doctors. Let's figure out when this happens. Does it happen in medical school? Okay, so we gave these medical students these clinical vignettes. We then would give them the IAT for race and social class. And then we asked them direct questions on race and class preferences. And these direct questions are not like very, very explicit, but they are thermometer scales, like on a scale of 1 to 10, who do you prefer, and so on. That's how these explicit measures work. And here's what we found. These are the IAT results for those medical students. And where are our medical students again? You're right there, right? Okay, you're going to help me add this up again? All right. So we're going to do 15 plus 30-ish. How much is that? We'll call that 36? Or, no, I'm wrong, right? 46? All right. And then you add about 22 more to that. How much does that become? How much? 68. So 68 is pretty close to 70, right? So I love showing this to medical students because our superstar, very smart medical students, we think, I was a medical student too, we think we're smarter than everybody else. But if you look at our unconscious preferences, they're exactly the same as what the general population is. And remember, that was 70% for the general population. Now, turns out that most of the medical students didn't think that they had these unconscious preferences. That most of the medical students said that they prefer on the explicit testing both equally. That's what most of the medical students said. In fact, if you look at the correlation, there's really no good correlation between what people's unconscious preferences were and what their explicit preferences are. Then we looked at all these clinical vignettes, pain, informed consent, reliability, trust, and so on. And when we look at them, and we looked at black versus white patients, we found that there was no difference in the way the medical students treated a black patient or a white patient on any of the clinical vignettes. And we also found, of course, no difference in, or no association between unconscious preferences of the medical students and how they would treat patients, because they treated patients all the same. So then we said, okay, maybe this has to do with social class. So let's look at social class. And amongst here, the social class ones, you know, most of the medical students had an implicit preference towards high social class. And there's no surprise there, right? Because medical students, you know, they want to become doctors. Doctors in our society make a lot of money. They're part of the high social class. So you can expect them to want to be part of the high social class. You know, they're going to become doctors. That's what they expect they're going to be. They're also going to have a lot of loans probably, so they need to be able to pay them back, right? And we looked at pain assessment, patient reliability, informed consent, trust, all these vignettes, and the data was virtually the same. No difference in how the medical students would treat patients based on their social class. So, okay, we're like, okay, well, we found that in the medical doctors. Maybe the medical students, you know, they're not differentiated yet, they're not jaded yet, maybe something's happened later on. And so we did 3 additional studies. We looked at surgical residents, we looked at nursing colleagues, and then of course we also looked at double board certified surgeons who are members of the Eastern Association for the Surgery of Trauma, EAST. And just so to explain how this worked, this was a web-based study, and we would get the surgeons to like log on. They would then do the IAT. They would then, first they would do the clinical vignettes, then they would do the IAT, then they would do the explicit questions. And we had about 250 surgeons do it. And so Arden, if you wonder how we got 250 surgeons to do this nearly 25-minute survey, it was a $200 Amazon.com gift card, and we were oversubscribed like within a week or so. This is what we found. We found, and if you think these graphs look similar, it's because they are. We found that the bias amongst the residents, was virtually the same as we found in the medical students and as we found in the general population. The preferences for social class were also very, very similar. And when we looked at the clinical vignettes and if these unconscious preferences impacted the clinical vignettes or how they would treat people, we found no association whatsoever. We then looked at nurses. The nurses' unconscious preferences for race and for social class, virtually identical to the residents and the medical students. But again, no difference in how they would treat patients on clinical vignettes. And for the nurses, by the way, those vignettes were built by our nursing colleagues. And there would be things like how you would make a decision on putting somebody in restraints, you know, things of that nature. And we did not find any difference in how the nurses would, at least on a clinical vignette, respond to a black or white patient or a high social class or low social class patient. So then we said, okay, must be the surgeons, right? And we looked at those members of the Eastern Association for Surgery of Trauma, and we again found nearly identical results for their unconscious preferences for both race and social class. And yet again, we did not find any correlation or association between how they would act on clinical vignettes. And of course, their clinical vignettes were built for surgeons, so they were much more advanced. They were 3-step vignettes. And they would test out all the time. Whenever we did validity testing, they would test out and you'd be able to find things on them. But when we associated them with unconscious preferences, we didn't find anything. So is the impact of physician unconscious bias different for internists and surgeons? And I put this slide in there because when we first did this work, the chair of medicine, when we first did this at Hopkins, you know, he invited me to give grand rounds. I was thrilled to go give grand rounds in the medicine department. You can just imagine, as a young surgeon, you go talk to the medicine department, and the day before he phones me and he says, by the way, I'm going to ask you this question. Can you please have a slide prepared on this? And this was the question. He's like, why is it surgeons different than medical doctors, right? And I think it has to do with, you know, when we really need to develop a strong relationship with our patient and understand what they need, right? That's when these disparities are more likely, or these unconscious preferences are more likely to cause disparities. You know, when we're doing trauma or some acute thing where it's very, you know, protocol driven, right? There's less chance for our stereotyping or unconscious preferences to make a difference. But when you have to really get to know somebody and come up with the best treatment plan for them, then perhaps it might make an even bigger difference. Another idea is this concept of in-group favoritism, right? And let me just give you an example of this, right? The other night I had a trauma patient come in, and it was a Saturday night, and he was smacked upside the head with a big beer bottle. He was bleeding very profusely. About 1 a.m. in the morning, he's quite inebriated, this 35-year-old man, and he's using lots of profanities, let's just put it that way, right? And now we needed to see if he has a head injury or not, right? So we try to get him into the CT scanner. He's not calming down, so he gets himself a social intubation. Not something we're supposed to be doing, but somehow he got one. Anyway, we get a CAT scan. Turns out, no, he has a brain, but no injury to it, okay? And so we, fix the scalp, bleeding's all stopped, stays the night in the unit, gets extubated in the morning. I'm rounding on him. I start talking to him. Turns out, he's quite the cool guy. He went to the engineering school that my older brother went to, University of Illinois, Urbana-Champaign. He lives in a really cool apartment on the water, a place where I would have loved to live before we decided we needed a yard and a house and all that stuff. Also, he had to go to his mom's house for brunch that morning. Now it was Sunday morning. And, I could relate to him that he wasn't super thrilled to have to go through all of that. And so I say to him, listen, I'll call your mom. Why don't we keep you in the hospital an extra day and have you meet with the alcohol counselors so that you don't go through this whole binge drinking thing anymore, right? Now, I created this bond with this guy, right? And I felt like I should do a little more. And I felt fine doing a little more because he had insurance. I felt like I could make a difference. Now, suppose this was a homeless patient who doesn't have insurance and who had no chance of getting access to alcohol rehab. Would I keep that person in the hospital a little bit longer? That first case that I showed you, or second case where I showed you, remember the open book pelvic fracture that I was showing you? Right? That was a 17-year-old kid who came in with an open book pelvic fracture, hypotensive. We took him to the OR. He had a bladder injury, et cetera, fixed all that. Now, he was in one of our private pavilions. And, his dad was this architect. When he got discharged to go home, they recreated this whole floor in his house so that he could get rehab at home. And I would always go around on him last. And I always felt like I spent a lot more time in his room versus other people's room. Turns out that this kid had the best video games, right? I'd go and play with him. His parents were very interesting. I'd go spend time with them. Why was I doing that? And was there anything wrong with my doing that? I mean, they're very interesting people, right? But I probably was spending more time with him versus other people. Now, another group that I just want to mention that suffers from disparities, and I just wanted to bring this up just to give an example of how we try to do our best with patients, and sometimes we don't know what we're doing, but sometimes we're completely doing something wrong with our patients. And you find this out through qualitative research. This is a viewpoint that suggests or predicts that there are probably 400,000 patients who identify as LGBTQ or sexual gender minorities who require acute care surgery every year in the United States. And I'm an acute care surgeon, so of course this is a big issue in my world. And so to look at this, we developed what's called the equality study. And the reason why we built this equality study is that I once had a person I knew who happened to be gay, and he was explaining to me that when he goes to the emergency department, he's very fearful of telling the emergency doctors that he happens to be gay, because he doesn't know if they're going to look down upon him because of that. And so this is actually a huge issue in the LGBT community, and that's why we created this study to come up with a patient-centered way to ask people about their sexual and gender orientation when they come in the emergency department. Because if you go to your family practice doctor, you can choose who you want to go to, right? But not in the emergency setting. And what we did is that we first did qualitative interviews of all sorts of physicians and patients We then developed a trial to come up with 2 different ways to ask this information in the emergency department, and we just recently finished that trial. But what I want to show you, just in the context of what we're discussing, is this qualitative research from the equality study. And if you look at the qualitative research and you find out what the patients are saying, there's a huge dichotomy between what the doctors are saying in the emergency department and what the patients are saying. Read these transcripts, right? The transcripts are saying, I'm fine if they ask me, and this is regarding sexual orientation, gender identity, I wouldn't feel uncomfortable, and honestly, I would feel like if they're trying to treat me, that it's really their business to know. You see, what patients say is that they want to be asked this question because it normalizes who they are. But providers are trying to be paternalistic and saying, no, we should never ask anybody these questions unless it's specifically relevant to what they have. So if they come with an STD, it's okay to ask them about sexual orientation and gender identity. But doesn't that work? It works the other way. If you only ask people about their sexual orientation when they come with an STD, then you think that everybody of a certain sexual orientation is going to have an STD. If you don't ever ask them that question on other times. And in fact, when we did a national survey, we found that only 10% of patients would not want to disclose this information about sexual orientation and gender identity. But 80% of doctors felt that they shouldn't be asking this information, or that the patients wouldn't want this to be asked. I show this just to show you the dichotomy of what we think we're doing right and what the patients actually want from us. And of course, this got a lot of press, and I just wanted to put this one up there just to remind, even when it gets to the lay press, by the time it gets to the lay press, they really distill it down. And that's what patients are saying. Now, to wrap up, I wanted to get to, now that we've talked about these mechanisms, or one potential mechanism, a provider-based mechanism for disparities, I wanted to talk about some solutions. And I'm going to go into much more detail tomorrow during the SPIRE discussion about how we try to create this relationship between the American College of Surgeons, the NIH, and others to come up with a national research action plan to solve healthcare disparities. But what I'll do here is just show you a very short video to explain how we brought lots of stakeholders together and then tried to come up with a research agenda to impact surgical disparities, and then what that research agenda is actually doing right now.
My name is Edward Cornwell.
I'm Beth Sutton.
My name is Lisa Newman.
My name is Henri Ford.
My name is Ramona Hussein-Winia.
I'm Michael Zinner.
I'm Stephen Stain.
I'm David Hoyt. I'm the Executive Director of the American College of Surgeons.
We have a multi-trillion-dollar industry. There's no other multi-trillion-dollar industry in America. But we have the greatest healthcare disparities of any industrialized country. That's unacceptable.
Before, in the literature, we always thought that it was mostly in the medical field, but never really thought that in surgery this would be an issue. And so it was a no-brainer for me to be interested in a collaboration to explore further surgical disparities in outcomes.
Over the last 2 days, we spent many hours trying to determine what are the most important issues that need to be studied to mitigate surgical disparities. And I'm very proud to say that I think we were very successful in doing this. We started in the morning on May 7th. We worked all day long, came up with nearly 400 or 500 different research questions that could be studied across 5 different teams. And this work was done by about 50 of the most preeminent surgeons and scientists from around the country, and they were aided by an army of staff, research assistants, and research fellows who helped get all of this process done. Those research ideas, they were all collated overnight, and the next day there was great lively debate about what's the top thing to study and how to prioritize things. And the group did a great job, and they stayed on task, They prioritize things top 1, 2, 3, 4, 5 for each of the different teams. And we now, I think, have a very formidable research agenda that both the National Institutes of Health and the National Institute of Minority Health and Disparity and the American College of Surgeons will be very proud of.
Of course, it takes a very modest surgeon to show a video of themselves speaking while they're speaking. But that's how we do it in Boston. So, but this work, bringing these people together, came up with this, led to this creation of this National Agenda for Surgical Disparities Research. These were the 5 research priorities. I'm going to go into more detail about this. But the biggest thing that came from this is that the NIMHD and NIH really put their money where their mouth was, and they put out this request for proposals and have funded 2 rounds of R-level awards. They've funded now more than 17 R01s and several R21 grants as well. So we're talking, $60, $70 million worth of research in this field for surgical disparities, which of course is something that we're all very, very thrilled about. And that has moved forward this field pretty significantly. Now, one of the first research priorities that we found was, or that this defined, was improving patient-provider communication through culturally dexterous care, right? And so, as you heard from the last 20, 30 minutes, I've been talking about issues with communication, right? Now, how are we going to solve those issues? And many people have proposed the idea of cultural competence, that, you learn a little bit about each different culture, and that makes you competent in those cultures, or at least that's the idea. The trouble is that you can't really be competent in, competency defined by proficiency that you can measure, right? You can't be competent in another person's culture unless you really live in that culture, right? And therefore, we're suggesting this idea of cultural dexterity. Now, of course, we're surgeons, we like dexterity. The idea here is that if we can give you a set of tools that you can rely upon so that you can appropriately navigate any discussion with a patient who might be from a different culture than yours, then you'd be able to do a better job in providing more patient-centered care. Now, to do this work, we started with what we call the PACS project, or the Provider Awareness and Cultural Dexterity Toolkit for Surgeons. Again, our goal here was to create a toolkit that people could rely upon. And we used this strategy: design a new curriculum, test it, and then hopefully do a national expansion of this. And here's kind of the steps we've been going through. We first started with doing qualitative interviews. And so these qualitative interviews were for surgical residents, faculty, and patients as well. We then brought all that information to a curriculum development workshop with experts and patients. And then we designed a randomized trial that I'm going to talk about in just a second. When we did all that qualitative research and brought the experts together, the most important thing we did was, I think, was that we brought patients. So you could see lots of experts that you might recognize around here. But in the front row, these are actually all patients. And they gave us great ideas on how the curriculum should work, but more importantly, what the outcome measures should be. So we, as surgical educators, were like, okay, we're going to do an OSCE. We're going to look at the knowledge knowledge that's been imparted to the residents. And the patients were like, no, no, no. You need to look at exactly how they treat patients. And they really challenged us to do it, and I'll show you in just a second what we're going to do. Now, each of the skills that we're trying to build through this curriculum are based on the qualitative research we did. And you could quickly just skim through what the patient is saying, but the first curriculum objective, or what the resident has said in this qualitative quote, but the objective here is to help physicians learn how to build a better relationship, a stronger, more trusting relationship with their patient. The second thing is to learn specifically how to work with patients who might have limited English proficiency. And I'll give you an example of how this works with, from the other night on call, we had a new young resident in the emergency department, very smart person, and had just taken over that ED rotation. And he diagnosed a patient with appendicitis, appropriately diagnosed the patient, appropriately booked the patient to the operating room, calls me and says, and he and I, we know each other well. He's like, Adil, book the case. It's now 2 o'clock in the morning. He'll be in the OR in about 45 minutes. It's a lap appy, and so-and-so is going to assist you. I'm like, great. I'll come down and say hi to the patient. He's like, oh, the patient's probably going to be in the OR by the time you get down. I'm like, no, I'll come down now. So I go down and say hello to the patient. Patient speaks Spanish only. I said, well, how did you get consent? And he said, well, you know, it's 2 o'clock in the morning. I asked the 10-year-old son. But this is a friend of mine, and he knows I teach this course. Right? And so I said, come on, man, you know, this is not right. We got to get the interpreter. He's like, okay, okay. We get the interpreter, and it turns out this poor man is deathly afraid of going to the operating room. Right? And when provided the opportunity to choose non-operative management, just get antibiotics, the very early appendicitis, no fecal, perfect for that, he chose that. So I almost gave the wrong operation, even though I do this work, to a patient, just because we were trying to be expeditious, trying to be, you know, quick in what we do. And so, you know, we felt like we need to really teach skills on how to work with limited English proficiency patients. Now, if you ever read a qualitative quote, you know, they tend to be long. But this quote is probably the shortest but most loaded quote you've ever read. Certain patients handle pain a certain way. Right? What do you think they mean by that? That's why we felt for number 3, our number 3 objective is to assess and manage pain more effectively for patients from diverse sociocultural backgrounds. And then, of course, the 4th, and we are surgeons, this is so important, what we do is to better lead meaningful, informed consent discussions. Right? And if you read this quote, it's a little longer. But what the person is saying is that if you don't really tell the patient what they have or how you're going to fix it, they'll just agree to it. Right? So this is beyond just cultural dexterity. This is also looking at, you know, helping us become better physicians. So this is what the PACS curriculum has. It has the physician-patient relationship, limited English proficiency, informed consent, and pain management. And this work was really mostly done by these 2 surgical fellows, Naveen Changur from Howard University and Ria Udevar, who came to us from Duke and now has stayed on at the Brigham as a surgical resident. What the course does is that it tries to teach these concepts through the lens of these 3 pillars, what I would say, pillars of cross-cultural care. And those are curiosity. You know, if I was curious of why Taishu Craig, and she's okay with me using her name, why that 16-year-old girl from Baltimore was not willing to receive care at day 17. If I was more curious, I probably would have been less frustrated. If I truly respected her, I would not for a moment have thought of her as ungrateful, right? And if I was more empathetic, I probably would have come to the conclusion that she was suffering much more earlier. And that's why we try to take all of those 4 things that I talked about and teach them through these 3 tenets. Now we've implemented the PACS curriculum. We started off doing pilot testing at the 3 HMS hospitals, Brigham, Mass General, and BI Deaconess, and we got have gotten some good feedback. We published the first set of results, and now we're in a trial. We just are starting the trial. It's going to begin enrolling in the summer, so if there was any other program that wanted to join us, they could. It's going to have 2 groups. Group A is an intervention group where we are giving the pretest, we do the intervention, and then we look for a long-term durability a year later. And then Group B, we're just going to do some pretesting. We're not going to give them the intervention till year 2, and then we'll see if the intervention works. So this kind of a cross design, and I think you'll like that kind of a design. The outcomes we're looking at, of course, we're looking at residents' knowledge, attitude, skills, and so on. But most importantly, patient satisfaction and clinical outcomes. And the way we're looking at patient satisfaction is that, and this was the idea from the patients again, is that you know, we're going to get lists of what patients the residents have taken care of, and then we're going to go to those patients, at least that's our idea, we're going to go to those patients, we're going to show them a picture of the resident and say, has this person been providing you care? Do you know this person? Okay, now we're going to ask you about that person and how they've been working with you. And we've designed the trial in a way that we have enough minority patients specifically that we'd be able to do it. That's why it's at 8, and now actually 2 more centers have joined us, so 10 academic medical centers. So with that, I just want to again thank you so much for allowing me to come spend the next 2 days with you. Dr. Hahn, you were just here. This is our group that you were on the expert advisory board. This is all the people that work at the center. And thank you so much.